Okay, since you all have given the consent of recording, and we'll also publish it on YouTube for all those who couldn't join this webinar. And I'm Dr. Pratyush Kumar. I am the chair-elect for Rural Wonka and currently chair Wonka Rural South Asia Group. And we are hosting a Global Rural Health Summit on 4th April this year. And you all are welcome to join this webinar, this summit in Bengaluru. And we will be very happy to meet you face to face there on 4th April. So next, and I'll also like to welcome Darmud, who's from Wonka Secretariat, who has done an incredible job in our last conference, and he's here to help us. And also, I'd like to thank Bruce, who's awake at 1 in the middle of night and is taking all the tough job to be here. So let's start from Darmud basic introduction, and we'll move on.
Hi, everybody. Dermot Hayes is my name. I'm based in Brussels, working in the Wonka Secretariat. And there's a possibility that I will be attending the conference in India. So I'm looking forward to meeting some of you in person.
Great, great. Bruce?
I'm Bruce Chater. I'm the chair of Rural Wonka. We'd love to have you there. Dermot did a great job at Ubuntu. So, and we're really looking forward to having this focused global summit on the needs and aspirations of lower and middle income countries, and particularly with a emphasis on South Asia. So thank you, Pratyush.
Yeah. Next is Kostas. And congratulations for all your accolades.
Well, we'll try and see whether we can. We want to pick him up, but
hello, Christos Leonis. I feel very privileged being among so eminent colleagues and friends. I was serving many years ago working party on rural health, and at the moment I'm serving as a chair the Wonka Working Party on mental health. Thank you very much. Thank you.
Thank you. Roshni?
Hello, everyone, and I'm Roshni from India. I'm the organizing secretary for the Wonka South Asia Conference, and it's I'm very happy to meet all of you. And Pratyush has done a fabulous job by organizing this Global Rural Health Summit, and we are all looking forward to it as well as the conference, and looking forward to meeting you all in person in Bangalore. Thank you very much.
Thank you. Suja? Suja Mohammed?
Yeah, I'm Dr. Suja from Sri Lanka. So I'm very happy to be part of this team, and thank you very much. I hope to work with you all in a generous way in the future as well. See you in Bangalore.
Yeah. Rick?
Hi, I'm Rick Patel, old-timer Wonka. I used to lead the behavioral health, behavioral change group many years ago, and I've always had a soft spot for rural health. I only spent part of my career there, and I just wanted to see what you guys are up to. I just think, rural health doctors are the unsung heroes of family medicine. So I take my hat off to you guys.
Thank you. Rafael? Kindly unmute yourself.
Hello, I am Rafael. I come from Spain, and I'm happy to be here.
Thank you. Govit? Your voice is not audible. Govit? Okay. Vikas, Dr. Vikas Kesri.
Oh, my audio is on already. So, my name is Vikas Kesri. I'm new to this group. Thanks to Pratyush for inviting me for this particular webinar and to be part of this group on global health from local lens. So, yeah, I'm a medical doctor and a public health researcher. Currently, I'm based in one of the state in central India called Chhattisgarh. In the state capital is Raipur, and I head a local health policy and systems think tank here called State Health Resource Center. Nice to meet you, all of you.
And Dr. Ahmed. Dr.
Hi
Ahmed.
everyone, hello. I am Dr. Ahmed. I am a Sudanese medical doctor. This is my first to join you. Thank you for this chance. Thank you.
Thank you. Thank you. Marilena.
Hello, I am Marilena Anastasaki. I'm from Greece, and I work at the University of Crete, and I'm a member also of the Wonka Working Party on Mental Health. It's really a pleasure for me to join this group, and yes, please let me know for everything. Thank you.
Okay, thank you, thank you. Sarita.
Hi, my name is Dr. Sarita. I'm from Hyderabad, India. I also work in UK. I've done my MRCGP from UK. I worked there for about 15 years. I thought, let me see what I can contribute for this position paper because I work both in Western world as well as in India.
Okay, thank you. And we have so many members, like Elif, can you hear us? Kumaran. Okay.
Hi. Hi, this is Kumaran. I'm new to this group and thanks for inviting me to join here. So I'm Dr. Kumaran. I'm a consultant family physician from Sri Lanka. My area for research interest is implementation science and women empowerment and introducing technology and data science in a poor resource setting. Thanks. Happy to work with you all and we will have a nice time. I will try to come to Bangalore and join with you all. Thank you.
Okay. And Paulina Solaris. Okay. Prem Adish Lekhi. So anyone else who would like to introduce yourself so that, yeah. Anyway, yeah, Elif, we can hear you right now.
Hello, my name is Elif. I am from Turkey. I study as a family medicine specialist. I study as a resident in Turkey, in Düzce City. It's my last year for family medicine specialty.
Okay, fine, thank you. And we have more number of people, but we'll just start with the basic introduction that what we are going to discuss here. We are going to focus on these 6 parts, which is equity and justice, sustainable development goals, primary healthcare, health system strengthening, research and development, and non-communicable diseases. We will go very crisp with all these subheadings for this webinar. We'll begin this webinar with Vikas Keshri talking about global health. He's written an article with other people on decolonizing global health. So I'd like to request Vikas Keshri to just give a brief introduction regarding the topic and how decolonizing global health is all about. And okay, go ahead.
Thanks, Pratyush. Thanks. Once again, welcome all and nice to meet you, all of you, this new group of audience. And I'm really excited to talk to all of you. And yeah, as Pratyush tried to explain lately I and few of my colleagues and one of my PhD supervisors, Bimbola, we have all been writing a lot about decolonization in global health space. And we not only write, we also reflect about how to proceed with global decolonization in global health. So before I talk about decolonization, I would like to give a brief introduction. And I think most of us who have some public health or medicine or allied sciences background understand the evolution of global health. So I think global health, if we see historically, emerged out of tropical medicine or tropical health, which was genesis of which started, I think, during the colonial times when developed nation were investing, in research on tropical health issues in erstwhile colonized state, and I think that loosely translated later on to become what we call international health. So there are a lot of talk about health being an international issue. Then come international health regulation, global health security is another cross-cutting domain here. Tropical health, international health, and now largely nobody is talking about most tropical health and international health, and even to an extent many public health expert is refancying themselves as global health. So what is global health? And there is no one definition. Different people see global health from their own lens, and they define it according to their own worldview and or reflexivity. When I will try to give a kind of overview about definition of global health, I would like to put a caveat that may not be inclusive and that may not be your view or your definition of global health. So there is no one definition, and there has been a long debate around how you can define global health. Like tropical medicine also can. Because many times the people from developed countries, they were in researching about tropical medicine in the erstwhile colony, or the places where this was more common. So that was very clearly segregated. Tropical diseases were not happening in the geography where they were researching, but they went to other geographic area to research. So that was very clear. And international health also was very clear, because international health actually mean that you are going internationally to work. So if I am based in India, if I am going to work on or research on a topic in Sri Lanka or like my neighboring country or faraway country, then I am doing international health. Now with global health, and this is very much in sync with the global development and kind of seamless transportation, seamless access to global public good for one and all. This and largely guided by IT revolution and other economic development. So global earlier in late 90s they talked about global village, and similarly we can talk about global health. So now if someone is saying that I'm a global health practitioner, it do not essentially mean they are international health practitioner, or they are a tropical medicine practitioner, or they are a public health practitioner in their own place, but we have a global vision or a global lens. So what essentially is global health? So one definition which was very popular, but then was debated and kind of debunked by many was like global health is doing public health somewhere else. So if I am living in India and central India and doing public health or public health practice or research, then I'm doing public health. But if I am doing public health in Sri Lanka or say Bangladesh or say anywhere, say maybe in Europe, then I am doing global health. So then people debated what is the difference between global health and international health. It's international health. Why you are bringing new term? Because if I am working in my own place, then I'm talking about public health, and there are lots of discussion about why we can't call it public health, and so many new terminology, like many new journals they are calling like PLOS global public health, or but similarly, many of the Western universities, especially, they started different programs, a master's program in global health, PhD in global health, or even in bachelor's in global health in many places. And when we try to inquire into that, so how it is different from public health. So they actually teach public health to the student with a kind of objective to train them to operate
Yes.
globally. So there are different issues there.
Yes.
But I think yeah.
So I'll just like to bring some other perspective, like those who teach global health nationally. I think what's the perspective? This is the perspective from the LMICs, that what we see global health, like people from West coming to LMICs doing research, but I just also want to understand the perspective from different countries, like where they actually teach global health, like in Australia. Bruce, do you have like in your university, do they teach global health, and is it there in the curriculum?
Yeah, look, I think there's a couple of aspects here, isn't there? Part of this is around public health, and I acknowledge that. I think our focus as Rural Wonka is around the global issues that are present in rural practice, and so I think that's what we're here about. And I think we've always said from our very first conference in 1996 that we share more in common than we have as differences. But I think what we've tried to do within Rural Wonka is realize that this is everyone's problem, and the solution needs to come from all countries, not just those who are developed or those who are in lower middle income countries. It's trying to get our heads together to say these are the common issues, and we can all learn from each other. I think it's the globalization of ideas that we're talking about here. It's about saying that there are some good ideas in Australia, but we don't know everything. There's some good ideas in Canada, but we don't know everything. Christos has some wonderful ideas, but he doesn't know everything. Let alone can we give you the solutions for low and middle income countries. I think the key differences in low and middle income countries do bring up the flavor of global health that's been in previous discussions, the sustainable development goals and all those sort of things. So the issues of in some areas deep and ingrained poverty, lack of sanitation, lack of health services. So there's some of the real danger that rural health workers can be in at times in isolated communities. So I think there's some key elements that are a bit different for lower and middle income countries, but the same issues around making sure that medical students see rural health when they're in an undergraduate course, making sure that there's proper incentives for rural, making sure there's proper facilities for rural, making sure there's proper training for rural. So there's some common issues, and then there's some quite palpable different issues that I think need to be highlighted in this global summit that bring I just want to see the view from this. We saw a lovely glimpse of it at the World Rural Health Conference in Delhi a few years ago. We saw a beautiful glimpse with some of it at Ubuntu. So that's where I would hope us to be focusing on is that. I hope that helps, Pratyush.
Yeah. So Marilena, your views on this?
Yes, thank you. I wanted to say that in Greece, I think that there is no undergraduate curriculum or course on global health. I know there is one postgraduate course called Global Medicine, Disaster Medicine, and they are mostly focusing on promoting international research, as we heard earlier, and giving some skills on disaster medicine. But we are trying at the University of Crete to bring forward the issue of global health, and we have been doing extensive efforts to focus on the concept from global to local public health. And that's what we have been trying to discuss with local, let's say, experts on public health and other universities. And we've presented our ideas in conferences. I have personally worked on global health in my PhD. I did it in the frame of a global health program. And I would like, through also this group, to learn more on how we can use the tools of global health to maximize impact in local health. And by that, I don't know, because Greece also has a very big rural community, and we are not typically a low and middle income country, but we have lots of disparities in Greece, deprived populations, people who lack access. So I want to view the local lens of global health in this frame, on how we can use all these tools to employ implementation science and scale up and adapt interventions and test interventions for specific populations. Thank you. I've found the draft very, very nice, and thank you so much. Yes.
Okay. So, so we move to the next subtopic, that is regarding the Sustainable Development Goals, basically the point 3, which we want to highlight. And as you all know that most of the LMICs are behind the targets, and we'll just take your opinions that what are the 1, 2, or 3 major regions which you see that why we are not able to achieve all the goals. Like if you take any goals like TB elimination was supposed to happen by 2025, and there's so many goals that we fail behind the target. And what could be the top 3 reasons behind that? And I'll go with Vikas. You start with because you have been working with the government setup.
No, I think the idea of I may, this is a bit of, I may be making a controversial statement here, but I think any setting up of such goal at global level is probably more of a goal, an aspirational goal. So, and which also in a way kind of stimulate local government and local policymakers, especially in challenging states or countries like ours, to stretch their capacity to achieve these goals. But except few goals like maternal mortality ratio and child health, infant mortality rates and other, I think others, it was, and tuberculosis, as you rightly said, they were kind of, chased very vigorously, but others were like not much attention.
Okay.
Yeah.
And I'll bring Dr. Basrat Ali. If you can speak regarding the SDGs, right? That what's the problem in not achieving those goals? Can you unmute?
Yes.
Okay.
I just joined very late. I'm just trying to understand what's going on now, then I will respond.
Okay, so we are discussing regarding the global health issues, and the next thing which we are discussing here is regarding the Sustainable Development Goals. And we are just trying to analyze that what are the reasons behind that why we are not able to achieve some of the goals, basically in the LMICs and in your country. What's the major challenges which you see that prevent us from reaching these goals?
The problem here in our country usually is non-compliance. Whenever we try to find out the solution, the people who are going to help or incorporate the system, the response is not usually up to the marks. One thing is, in our country, the structure of the family medicine practice is not decentralized. It is the, people who are practicing as a doctor, as a corporate, they are doing it. But we are lacking a comprehensive standardized system here in Pakistan. So that is one important reason we are not able to achieve the goals. One. Second, response from the responders. We have response, but sometimes we don't have the response. The variable nature of the response is there. The most important problem is this non-structured family medicine practice in our scenario.
Okay. Okay. So I'll take another views from Roshni. Can you hear us?
Yeah, I think as Dr. Bashrath was pointing out, I think first and foremost is the structured family medicine training, or rather lack of empowered family medicine specialists. We do have, but we are often working in silos. So I feel that in a country like ours, and with a population as big as ours, a decentralized approach, uh, empowering the local community health workers, incentivizing the doctors and the healthcare staff to get motivated to work in rural places would be a desirable outcome, is what I feel is important. And thereby, because of not having the structure in place, or we are working in like localized, like in silos, what is happening is there is lack of resources. People are not motivated enough to go to the rural places. Certain urban doctors do take the initiative to go to the remote places. They work in forms of NGOs, in forms of trusts, so that is how they are trying to help. But if we have a decentralized approach, and if we can work together and have a structured approach, I think we will be able to work on it. Thank you.
Christos?
One thing very, very important is that is when somebody is practicing in our system, the people who are having they are giving services to BHU or HC centers, they are like MOs. They are not quite trained as a family medicine person. So the vision they have is not of that which we should have. And they are not so able to transfer all these to the paramedics. And these people who are serving in BHU or HC center, they are MOs, medical officers. But they are not having structured training program of family medicine. It should be there to incorporate these people in the services. So, but I think that family medicine practice in BHU, in RHC, and in tertiary care as a filter clinic is very important, but not yet. We are waiting for this to occur.
Okay. Christos, your comment?
Thank you very much. I enjoy very much the discussion. I think that's very fruitful. I'm strongly suggesting to combine sustainable goals with an excellent document, WHO document, after a standard declaration, a new vision for primary care, or explained, or 13 levers have been proposed to make a connection between local needs with the global issues. I think that is very important, just combining sustainable goals with a standard declaration and the new vision for primary care. Thank you.
Okay. Okay. I think we need to also have a proper teamwork where not only family doctors, but we also have nurses, the community health workers, and they're all trained to deliver these goals. I think we also need some kind of family medicine training for all the nurses and also the support staff so that they can also work in sync and they also have a common vision to reach those goals. And for that, we need this very strong primary health care. And uh, do we have some other comments, Suja? What's your views? What you see in your country? Yeah, please tell. Dr. Ahmed? Yeah.
Yeah, I am from Sudan. We have a lot of challenges in Sudan regarding there is a conflict area, there is arms, there is a lot of violence. There, moreover, also there is a problem in access to health services, especially in the rural areas. How to overcome for this? There is a lot of NGOs work peripherally. For example, they can use not only family physicians, but also medical doctors and community health workers. For example, I launched an NGO. It is called Pulse of Life Organization. It is working in Eastern Sudan. By this NGO, we developed initiatives. It is called Prevention Ambassador initiatives. These can deliver a lot of campaigns, health services, especially in the non-NCDs, non-communicable diseases in rural areas.
Okay. Susan?
Yeah, I agree with most of your ideas regarding the policy making and implementation. As I am also from Sri Lanka near to India, so most of the things goes in hand. But rather than this policy making and other implementation fact, there is another fact we always tend to forget is the general population or the patient or the target group which we are going to act. There are a lot of myths regarding non-communicable diseases. So the people, even though we give them advice, we give them drugs, they tend not to accept it. For example, the recently day before yesterday, I have seen a patient who got stroke due to the non-compliance of his hypertensive drug. Then they have put on 300 milligram aspirin for 2 weeks. Then she called and asked me, shall I take 150? Isn't this 300 is too much? So rather than the policy making and the implementing, what we need is the proper patient education. Because that is very difficult because there are myths around the world. Some people still believe the non-communicable diseases are given by God. So there is no point of getting treated. So a proper education for the population and the target groups, workshop, this should not only done by medics like us, rather by the community leaders like priests, mosque leaders, church fathers like that. So if we can get enrolled, there are things, and I think it can be very easy for us to give an idea to the general population. That's my a different kind of perspective when regarding controlling this.
Okay. Eric?
Yeah, well, thank you very much for letting me speak. I'd just like to maybe pick up on a point that Vikash mentioned earlier about decolonization of global health. I was very intrigued by what he meant by that, but I'd like to give a different perspective on it. You started off with equity and sustainability, and all of these problems are interconnected from complexity science point of view. And as people have been talking, I've been using my zoom lens. People are zooming in, zooming out all the time on different aspects of the conversation. And I think that's critically important. The thing that I'm interested in is zooming so far out that you go to a meta perspective, look at the big picture. And I'd like to introduce the notion of equity meta governance as a way of combating or enhancing decolonization of global health. I'll just put a resource in here that people can look at. I'm just throwing it into the ether so that people can look at it and think about it, but not to be discussed now because it's a complex topic. So thank you for letting me speak.
Yeah. Sarita, can you speak on this?
I think most of the points are covered. To add to what has already been discussed, I feel the other factors like environment, transportation, and the financial support. For example, a person has TB and the treatment is 6 months or 12 months in low middle income countries. And if that person is the breadwinner, in India, I don't think they get much financial support, whereas in Western countries, they do get a lot of financial support from government. And the public health versus family medicine, there is some sort of collaboration. However, there is no clear fund allocation or clear connections between the two departments. So I think strengthening the communication between public health and family physicians, and also associating with governments about environment changes and financial support would help dealing with achieving the sustainable development goals 2030, especially vaccinations, immunizations, eradication of TB, and treatments of HIV, etc.
Yeah. Yeah, I think in all our discussion, what we miss is we talk about doctors, nurses, healthcare workers, but we sometimes miss the patients for whom we are here discussing everything. And it's also important that in our team, how we take their views. I very much appreciate the comments made by Dr. Bruce that regarding the patients. Usually now all our conferences, it's more focused on from the curative perspective. And in this era where we're talking more about the personalized healthcare, the patient's perspective is also very important. And we'll discuss more on the primary healthcare and health system strengthening perspective. And I'll take some other views that what's happening in their countries and how do they see the primary healthcare. So I'll take comments from Larissa. Can you hear us? And talk about what's happening in your country and regarding the primary healthcare system in your country.
I'm sorry for my voice. I'm from Brazil, and I was thinking while you were talking that we need partnership. We need multiple stakeholders working together, and I think I very appreciate the vision about the patient's vision, but we also need like in Brazil, we need public and private health to work together. That's what I think. Sometimes we have a lot of regulation. In Brazil, we have lots of laws, but we still have difficult of reaching out our universal health coverage, for example, as something practical.
Okay. And someone, Mary Fabiola, can you hear us? No. Okay, Dr. P.S. Salma, please tell something your perspective.
Good evening, everybody. And just following all the proceedings, I'm very happy to associate with all the elders and from friends from different countries on this wonderful occasion. I congratulate Pratyush Kumar for organizing this program. And I have just kept my two important points on in the chat box. Number one is involving the professional bodies, IMA, IAP, API, etc., wherein all the doctors will take part and participate and contribute their might and spare their time, especially in health education programs. Secondly, involving the NGOs like service clubs like Lions and Rotary, and also the other NGOs where they can, more stressing on the health aspects of the community. So these two important points are very essential to achieve the SDG and also very important for the global health. Thank you for the opportunity, and I will be very happy to associate with all the programs being offered from time to time. Thank you very much.
Thank you, thank you, thank you. We'll take some other perspective. Andrew, can you hear us? Hello, Andrew?
Hello.
Gobit? Yeah.
I'm sorry, I just joined in and I'm so sorry I
Okay.
came in late. I was in a meeting somewhere.
Okay. So, Gobit, are you there? And we'll move to the main important discussion regarding the research part, and I'll ask Christos to speak on research, how we can do much better than what we are doing now, and what are the areas where we lack and needs much more attention. Christos?
That's true. It's a challenging question. I'm thinking very much, and now it was the time I'm trying a little bit in addressing this question, and I'm planning sending some thoughts. I'm thinking that one area that needed a further strength and evidence is so-called integration of public health and primary care. I'm thinking that many of our colleagues already stressed the need in closely working public health with the primary care, but still we needed more theoretical models in explaining, and such integration of public health and primary care needed a thorough evidence, especially from theoretical models. Even in Europe, and I'm thinking that not only from UK, but from other countries, still the subject has recruiting attention, but still I'm thinking that there are many issues to be raised and to be approached. I think that we needed a thorough investigation and an investment on research based on that subject. Thank you.
Okay. Bruce, your views on what are the research works, and also regarding what's the approach of WHO?
Yeah, look, I think we have some good research now, for instance, in rural health workforce, and that's the basis of the WHO guidelines. I think what we need is the research that looks at I think as Christos just said, how do you implement, particularly what's the most efficient way of implementing public health programs, and particularly in low and middle income countries. Because as you said, Pratyush, the Sustainable Development Goals are falling behind. And the reason for that is that it's a very central system. I think we're also getting a bit of traction with WHO on what we call rural proofing. Rural proofing is an unfortunate term. It sounds like it's fixing things near the end, but rural proofing needs to be real policies that work for rural areas, and they should be based on the evidence from and developed by rural doctors, rural practitioners, rural administrators. So those two areas of progress at the moment: workforce and rural proofing around rural equity. But I think we need the focus, and I think it's that 80-20, 90-10 gap of research. A lot of research is based in very developed countries, and we need to see more practical research from low and middle income countries to say what are the solutions that work there. It's about fixing the problems of everyday people in rural communities. So I think there's some that can be applied, but there's also the need to have some that's comes from the wisdom of countries such as yours, Pratyush.
Yeah. So we have a few comments in the chat box, and I'll ask them to respond. Paulina would like to talk.
Hello, can you hear me? Hello?
Yeah, we can
Okay.
hear you. Can you please?
So,
Yeah.
I would like to add that it's very important to know the community. Sometimes, well, I work in a rural clinic, and we need to have people from the community for us to be able to have a credibility with them. They don't accept help from people who is external. So that is what I wanted to add. It is a very well, a lot of information was already given, so that is my what I can give here from my experience.
Okay. Anyone else? Margarita, would you like to discuss something regarding the primary healthcare in your country?
Hello,
And
I'm sorry. My sound conditions are not optimal. So it's difficult for me to participate. I just wanted to thank you for this opportunity and to be able to.
Okay. Dr. Kishore Madhavani, can you hear us? Anyone else would like to discuss something regarding what's happening in primary healthcare in your country and what are the challenges and which you see and what are the scope for improvement in primary healthcare? I'll go back to Vikas Keshri, what is working in the primary healthcare system and the role of the community health workers and what do they see in the project which they're doing the Chhattisgarh?
Two things, I think. One is not all, so community health workers. Chhattisgarh is one of the largest community health worker network in the world. We could, in terms of density, because we have community health worker for almost every 300 population. But beside that, there has been, I am not sure if this group is aware about recent reform in comprehensive primary healthcare in India through the kind of redesigning the first level of contact, which was earlier called sub-health center, into a health and wellness center, or now they have renamed it to Ayushman Arogya Mandir. It's an Indian name. So there they are posting a mid-level healthcare provider called community health officers. So these are essentially as nursing graduate or sometime allied medical graduates who are hired to kind of, to lead this health and wellness center and not directly prescribe medicines, but dispense medicine, do follow-up, check-up, and, examine and provide first level of primary care for non-communicable disease and other services. So these two things, I think community health worker is now old, but this comprehensive primary health care through CHO and health and wellness center is new.
I think you brought a very important point regarding the mid-level health workers, because that's the area where lots of discussion is happening. I'll just take the views from what's happening in Pakistan. Do they also have the mid-level health workers in place? Dr. Bashrat?
In Pakistan, we have the midwives, we have the paramedics. We have the experience of the treating tuberculosis, and I'm training for the Mercy Corps in Pakistan. And I have done 50 workshops of combined GPs along with paramedics and the lab attendants and the patient's relatives. So it has been very successful program to control TB in such a case. So whenever we take the help of the media, the middlemen, the patient's relatives, in any program we are successful. TB is one example I have to tell you. So I was involved in the training and in delivering of then also the to control the data of from the patients and the paramedics and whatever they are. So this was a successful program. So whenever we take the help of these people, we are successful.
Okay, and do they also dispense medicines?
No, they don't discuss medicine. They just help to have the data, the
Okay.
test, and the compliance of the patient to take the medicine.
Okay. Okay. I'll just take opinion from other developed countries. I think in developed countries, they do have a role in dispensing the medicines. Bruce, in Australia, do they dispense medicines also? Like at the point of first contact?
It's mainly pharmacists in Australia do the dispensing. But certainly in some rural clinics, the primary care worker, whether that's a remote nurse who might be dispensing medicines and prescribing medicines. I think in the higher income countries, there's been this separation of dispensing and prescribing, so that there's a two-step process as a check and balance. But I think that's a luxury really in those areas, and sometimes unnecessary. I think the local worker knows what's needed and can get on and do that. So.
Okay, thank you. And we'll take some other views and then we'll take some final comments. Christos, what's happening in your country regarding the mid-level health workers?
We have in a reform at the moment that Greece is an example or many investments without success. That many times reform have been failed down, and I'm thinking that we can use it only from the negative approach. But the most important now is, as already discussed by Marilena, that I think that is important a little bit in thinking how we can change a role for primary care in a country where unfortunately invested only on physicians. And I'm afraid that now primary care in Greece has enormous efforts in giving a role not only to physicians and thoroughly ignoring the contribution of primary care professionals and teamwork. And I'm thinking that especially in countries like Greece, where actually is a European country with many disparities and many inequalities, I think that the focus is needed, of course, a central role to primary care physicians, but you needed to just invest in also and exploring the role of allied healthcare professions. Thank you.
Okay. Rafael, can you comment on this? Okay. So anyway, what we are going to do is that we will just going to end this webinar with your final comments that regarding what challenges do you see in achieving strengthening primary healthcare, and what's worked for primary healthcare in your experience? Just give me one final comments that what the challenges which you have faced and the opportunities or the success which you have seen in the strengthening primary healthcare. I'll just start with Christos and then I'll move.
Yes, I think that also, as already we have stressed in one of last letters sent into the Lancet, focus to leadership. We needed to invest in our workforce and especially to leaders that they driving now the forces. I think that is the most challenging for me. Thank you.
Yeah. Bruce?
I'd concentrate just, I think, on a couple of things. One is growing the local team, so what we call grow your own, that the people who are in rural areas need to be the solution to rural areas. Equally, I think the other thing is that's been successful in many countries is that we need to get medical students, nursing students and other students training in rural areas for extended periods of time. So whether that's one long block or multiple blocks, but many of your countries, when I go to rural areas, there are no students, and they cannot be what they cannot see. So you must have students in rural areas. And the final thing is obviously being completely unashamed of asking for an equal investment in rural areas compared to urban. And I think we're often too sensitive that we might be criticised by urban areas. Too bad. So sad. That's not our problem. We need to be advocating to say we need equal, equitable investment in rural areas. Thank you.
Vikas?
I think most of the point are covered, well covered by Bruce regarding investment. I definitely need, it has to be, inverted triangle. More investment in primary healthcare will lead to more solutions. So the investment has to be inverted triangle.
Yeah.
Besides that, no commitment is going to help. Yeah.
I think we need to spend more on preventive healthcare and promotive healthcare, and the actual need for curative healthcare will automatically come down. And next is Dr. Ahmed. The final comments.
Yes, thank you. I want to add something regarding the human resource. Is very important. Human resource, the capacity building. For example, in our country, in Sudan, and we face a lot of problems regarding the health system. Recently, regarding this conflicts area, there is displaced, especially for professional healthcare outside Sudan or internal. These make a lot of burden about to our system, health system. So a lot of solutions could be after this bus, especially training. Like for example, this my participation in this webinar is very useful for me, and I will share it also to our colleagues. This first, a lot of things regarding the global health. For example, in Sudan, there is no curriculum regarding the global health in the curriculum, especially in undergraduate. This one, a lot of things. Although this, there is chances for training online. For example, there is useful website. It's called Global Health e-learning. It is supported by USAID. Since 2020, I joined it and learn online regarding a lot of courses. Training is free regarding the global health, for example, and this is very chance. For example, logistics for health communities, how to do also knowledge management for health, and so on. Okay, thank you.
Thank you. Dr. Bashrat Ali.
Yes, what we achieved and what good thing is in Pakistan, we have the training of the MCPS, MRCGP, FCPS in Pakistan, and we are able to convince the government, the PMDC, that there should be 80 lectures to the curriculum of the 3rd, 4th, and 5th year medical students of family medicine practice. But the challenge we have the research. I have tried my best in a couple of years back. GPs are not interested usually, or they don't have the time, they don't have the ambition or incentive to research. To have the real data from the GPs is my challenge in Pakistan.
Okay. Dr. Kishore?
Thank you, Dr. Pratyush, and good evening, everyone. Actually, you earlier invited me, but there was some technical issue. Now, actually, being an occupational physician, we have tried through ICO to integrate basic occupational health services into primary healthcare. Training of doctors and paramedics at the primary healthcare has been done regarding educating farmers on the safe use and disposal of pesticides and ergonomic use of the different tools for agriculture. But still a long way we have to go. A lot of challenges are there. how we percolate down to the people and explain them the right techniques and their willingness to get aware and get skilled in the safe use is still a challenge for us. So maybe in this Wonka conference, we get an opportunity, we could have a meeting and decide the way forward. Thank you.
Larissa?
Yes, in Brazil, something that worked really well was the concept of social participation. So I think we have to invest in education, literacy for health for our patients, and actually give some empowerment for the communities.
Okay, thank you. Suza?
Yeah, what I feel is a nutshell, there are three important factors which affect the urbanization healthcare versus the rural healthcare. We can point it out briefly, like funding and the patient perspective, then the third is the environment. So these are the three factors, because we can talk it on for hours, but I would just point it out as we are coming to the end of this. So I am very happy to be part of this Wonka family, and I hope to work with you in future. And I want to tell you one message. Dr. Gopi's internet connection has some technical issues. That's the reason he was unable to join. He wanted me to pass the message for you. Okay?
Thank you. Thank you. And we have received few messages from Margarita also, and it's well appreciated. Thank you. And Dr. P.S. Sharma, your final comments?
Yeah, I mean, primary care, the challenges, I feel, so primary care in the government sector and primary care in the private sector. I'll divide into two aspects of it. As far as the government sector is concerned, still, especially in India, in agency areas, especially I'm from Andhra Pradesh, there are still some agency areas where the accessibility is not available. Accessibility to the medical care is not available, and also the availability of the medical care is not available in many parts. That's one challenge. Second one is awareness, as I already told you, awareness especially the illiterate people, because illiteracy is much rampant also even at this point of time, in spite of all our technological advancements. And so awareness is another important point. Coming to the private sector, but actually the government is supposed to give all encouragement, but on the other hand, if they are being hard pressed and much cornered and pressurized for all the permissions and all, and also not much of encouragement is given to especially to the people who want to settle up in the rural areas. So this is another important challenge in the private sector. This is my input, sir. Thank you.
Thank you. Thank you. Anyone else would like to give their final comments? It's very much welcome. Because access is something which is very important, because that's what differentiates rural from urban, and it's a key factor. And with these comments, I'd like to end today's webinar, and I'd like to thank all of you for attending today's webinar. It's been wonderful to have you here and receive all your comments and feedbacks. There are much information there on the charts also. And anyway, we'll publish all the discussion which we had during this webinar on our YouTube channel, and I'll share the details with you. In the next 2 weeks' time, we'll again meet with another topic, and I'll share the link with you all. So thank you all for joining us.
Thanks very much. Thanks very much.
Ongoing. Thank you.
Thank you so much. Bye-bye.
Thanks,
Bye-bye.
Pratyush.
Thank you so much. Bye bye.
Bye.
And thanks to Roshni also coming on the.
Thank you. Thank you, sir. Thank you.
Thank you.
Thank you, Damud, for all the help.
See you next. Thanks a lot.
My pleasure.
Yeah. Please also send the recorded link to me whenever it's available, so that we can publish on YouTube. Thank you.
Sure, I'll do that. All right, thanks. Bye.
Thank you, Dr. Izaz Anwar, for joining us. Thank you. It's been great seeing you after a very long time.
Wishing you all the best. The conference.
Thank you. Thank you.
I'm sorry I was a little late.
Ijaz Anwar, I also welcome you on
Thank
Thank you, Dr.
Thank you very
Putri.
much.
Thank you.
Thanks.
Thank
See you
you.
again.
Bye-bye.
Okay.
Bye.
Bye.
Bye.